Thanks, Sashi. So my disclosures and credentials haven't changed since yesterday. So I wanted to give a bit of a light-hearted talk about a serious subject, and a serious subject, often people come away with a flavor of kind of depression and disappointment, but with most things that are disruptive and problematic, I think it allows us an opportunity to change things for the positive, and that's what hopefully this talk will be about. So I looked up what tourism was, and tourism is formed from these old words in English, French, and Latin. And my recollection of a lathe from design and technology years and years ago at school was one of these things, which can do a hell of a lot of damage. And I think that's why I engaged to put this picture on the slide when it comes to bariatric tourism. Patients are getting more informed, they understand better which questions to ask, and now there's lots of things online to decide how should a patient pick which one of us does their operation. There are loads of excellent surgeons, and most of them are in this room. Okay, most of us have international patients, and most of us will go above and beyond to explain everything, consent them, and make sure that they have a pathway that we feel is safe, have good follow-up, nutritional input, psych input, and all the things that we endeavor to give all of our patients at home. But it's difficult and it's challenging, and if you do that for patients who come here just to have a procedure, that's not really what bariatric surgeons are about, and I'm sure you'll agree with me. The Daily Mail's put it as bluntly as most could. Gastric bandits was a headline a while ago, and one of the negative side effects of tourism or medical tourism that goes wrong, unfortunately, falls on the shoulders of us as a specialty, and it makes the specialty look bad. And I think that's terrible for what we're trying to achieve. This is back in 2013. My colleague, Mr. Ahmed, made this statement in the BBC News. It was interesting to see that 6 years ago that Jeremy Corbyn was still promising real change in his election pledge. For those of you that read his manifesto and the changes, that would interest you, I'm sure. Anyway, back to bariatric tourism. So the Canadians have had a problem with this for a while, and the Canadians looked into it and tried to answer the question about who holds the responsibility of the cost. And I think in a public healthcare system where austerity is the burden and will continue to be so despite whoever gets in on December the 12th, cost is going to be an issue, and that's something we're going to talk about. So Dr. Snyder talks about another paper of one of his colleagues, and if we look at that in a bit more detail, which is David Kim's paper that he was talking about, he suggested that at that time in 2015, that in one small area of Canada, they were spending $500,000 to treat 59 bariatric patients that went and had surgery in other places. Interestingly, they don't tell us how much they spent on bariatric complications of their homegrown patients. This is Mr. Kim's table, and using their conservative estimates, they came to this number. And it's a lot easier to find costs, I think, in that particular healthcare system because the coding and the billing goes hand in hand, as I'll explain to you in a second, because trying to find out the coding and the billing for some of the numbers that I've had to approximate to give the rest of this talk has been a real challenge compared to if these were all private patients, for example. So bariatric tourism is obviously interesting a lot of people. This is a group where Harris has been involved in and written a paper, as Harris writes papers on most things nowadays. And I know that Chetan has spoken about this in IFSO as well. So the interest is there, and the interest is because we don't want harm to patients. We are not cosmetic surgeons. We are bariatric surgeons that want to increase the health and reduce the morbidity of our patients, and follow-up and proper pathways are key. So why do our NHS patients go abroad? Well, we have a really long waiting list and they don't want to wait. Totally understand that. They get great cost deals, and I will show you some of these in a second, because all you have to do is put cheap bariatric surgery or cheap weight loss surgery into your phone and you'll get most of them. Some of our patients that go abroad, in fact a lot of these ones that I'm going to show you in a second, did not fulfill nice criteria, and if we saw them in the clinic, we would not be able to put them through an MDT and put them on our list. So there's something to be said about that. Word of mouth. Some people get great outcomes. A lot of people get great outcomes. So they come back saying, I went and had a holiday in X, got some sun, they flew me out there, had an operation, I got thinner, I came back, I met a guy or a gal, it was amazing. And that's the things that seem to be on the internet. Advertising, which I'll show you in a second, poor local experience of either tier 3, which I won't talk about, but there you go, or patients that don't want to have psychological input, which is absolutely crucial for life-changing operations like bariatrics. So if you put in bariatric tourism, this is the first hit you get on Google. A whole company to provide treatment abroad, getting sponsorship from all the various different private hospitals that a lot of us work in, so they can try and engage with those patients. NetDoctor helps patients to go abroad to have surgery. And who did they get sponsorship from? Spire Healthcare for advertising. Put in overseas weight loss surgery. What comes up? Half the price, all-inclusive package, liposuction in Prague. Forgive me, Czech surgeons if you're here. But this is what comes up in Google if you put them in. And every single one of these has got Google ads. So someone is paying to get these people up there on the Google website credentials. So these are the first things that people see. It's a business. Our business is run here. I'm very lucky to work here. This yellow building is the Patterson wing. It was built exclusively with bariatric surgery, robotics and things in mind. So I understand how privileged I am. When I was a medical student in 1993, I did my secure psychiatric placement because that's where psychiatric patients were kept in West London, so it hasn't changed very much to this day because it's us. That's a very original picture of our operating room when it was first built. And we are situated in a very unique place geographically, which is why I think the number of patients that I'm going to talk about over the last 9-month period, I'm able to talk about, because we are 15 minutes from Heathrow, 30 minutes from Gatwick, 24 minutes from Luton, 47 from Stansted, 22 from City, and even Southend is not that far away. So people get on a plane and they look geographically for a bariatric unit and come to us. We're also extremely easy to get to on other travel networks. So I think part of the reason we're getting the influx of this group of patients is because of our geography. So one of my old bosses, who's a colorectal surgeon, told me something that I think George just said. If you have no complications, you either don't operate or you're very generous with the truth. And I think we all agree with that. So we're going to get complications. And in bariatrics, if you have no complications, I think the former is true. But we have to deal with them. We have to prepare the patients for them. We have to prepare the team for them. And it's not just the burden of the patient, but it's the burden on the team. Some of the most challenging patients are the patients that my specialist nurse practitioners and dietitians, who very kindly come and sat over there, call me about to say, what are we going to do with these people? Because they feel the pain more than the surgeons do sometimes. And we have to be wary of that for the team. So when we have complications, we should know that we've done everything we can to avoid it and sort them out. This little inset is a patient who has flown back, who flew back within 48 hours of having a single anastomosis gastric bypass, and who was having a significant upper GI bleed as they came off the plane. So, at our centre from January to November, 25 patients eligible for NHS treatment went abroad and then had complications. Of 25 of these, only 5 live locally to our hospital. 2 patients had surgery in their home country and then ended up in the NHS. Okay? In the same time, we did that number of cases with 40 readmissions and 5 reoperations for various complications. So the procedures that I'm going to talk to you about briefly are, so 6 balloons, 4 bands, 6 sleeves, 4 Rowan Ys, 1 open Rowan Y, and a half a dozen single anastomosis bypasses. This is where a lot of them came from. The colour purple relates to Jordan and relates specifically 9 of those to 1 surgical centre and 1 surgeon. We're trying to feed back, not with much luck. So, balloon issues, displacement, pain, vomiting, all the normal things that you get, but the things that if you got as an individual here, you would rush to sort your patients out about. You can't rush to sort your patient out if you stuck them on a train, plane, or other automobile within 48 hours and they are now a sea away from you. So those patients are essentially being, and they have no follow-up either. They are just a financial figure. Okay. There's one I just wanted to point out. There's this patient here, the balloon after a sleeve, my particular favorite complication. Same surgeon, did an operation, member of staff at his hospital, lost weight, put weight back on, told them that special technique, only just filled the balloon a little bit, okay, into a sleeve, okay? And that woman is in a disastrous state, okay? A few slip bands, these things happen. Other common complications, okay? Then a few more that are not so common and take a bit more of intervention and a bit more time, more patience. And a lot of these patients, even though they live in the UK, go abroad because that's their primary home country. So we have lots of issues with language, expectations, psychology. It's very challenging, as I'm sure all of you have been aware of. So of these 27 cases, none had gone through a tier 3 equivalent, seen psych and diet, or had an MTD process. None. None had follow-up. 20 were not given any nutritional information or supplementation whatsoever. None of the stapled procedures were discharged with acid suppression. 13 were not eligible for surgery from our guidelines. 6 balloon patients were not morbidly obese or supermorbidly obese. 20 patients' issues that we saw were between post-op day 40 and 30. So these people are having things and being booted on a plane and coming back. Of the 27 cases, 3 were convinced and told and had the paperwork to say that they had gastric bypass surgery. But on imaging, endoscopy, and laparoscopy for some of them, they had had a sleeve. Another case, which was December of last year, so I didn't put it in the database, but I just wanted to point it out, was a lady who went abroad to have a band, never had a band filled because they put a special band in her that never needs to be filled or defilled. She had no injection site, nothing palpable. So we scanned her, and there was no tubing, and there was no band port, but there was some form of prosthesis around the top of her stomach, bottom of her esophagus, which was a silastic band, which we took out, got some photographs of, which had been cut, and then sutured together with proline around the gastroesophageal junction. So stuff happens, and I'm sure it happens all over the world. How can we manage it? These are clinically demanding cases with all our different specialties involved. Difficult medical legal issues, difficult communication with little or no family support, loads of psych issues, and it really is difficult to get information from the surgical teams that we've tried to contact. Some are more forthcoming, some are just don't pick up the phone or reply to your emails. So these are the values of the NHS Constitution. I think they are good values. So we will continue to look after all these patients because I believe in the NHS and we're going to have to help everyone because these poor souls have made some bad decisions. They've turned up here and we have to sort them out and help them out. That's our job. But there are some costs involved. And these will differ from hospital to hospital depending on your postcode and a few other things. But I have taken these from several business offices who have contacted DH to get the best rounded cost. So, on a ward, about £400. ITU, just under £2,000. 2-section CT scans, about 650 quid. An ultrasound, just over 200. An MRI of 2 sections, 710, and a diagnostic OGD, 900. Okay. So, the longest stayer, about 50k is what's been spent on them, and that's because there's lots of issues and there will continue to be lots of issues by the time said individual gets anywhere near home. But this is a very rough calculation for this person, and this is one of the 27. So how can we prevent this, and how can we use this as an opportunity to reduce some of these costs? Well, I think we need to provide a better service, and I think all of us go above and beyond for our patients, but the system is painful, but I think this may be an opportunity to get together as a group of surgeons and bariatric units in the UK to share our data and actually take it nationally to say our patients are flocking abroad because we can't operate on enough of them, Secretaries of State for Health. We have a lot of people hanging around in Tier 3. Our waiting lists are huge. We do not get capacity for beds when someone else needs to do an operation. This is an opportunity to start that dialogue, I think. Number two, let's educate the public a bit better. Let's ask them to ask these surgeons about their data a bit better. And I think we should have a group, maybe through the IBC for the patients or some other social media platform. I'm not very good at social media. I can't see Harris, but he's the world's expert at it with Kamal. So we should get together and tell our patients, these are the things you should ask, and if you're going to go abroad for bariatric surgery, by all means do it, but do it safely, and let us know why you're going abroad and what you're doing. We need to teach our patients how to use the NHS, because A&E is littered with people with cough and cold and not actually accidents or emergencies, and we're not getting the right people to clinics, and we need to educate our GPs to refer our patients better. I think we need to regulate the providers if they're going to advertise their services here. One of the individuals that is the recurrent offender off that slide comes to Harley Street, doesn't see patients as a doctor, is not GMC registered, but has a package of less than £2,000 for flight, hotel, OAGB, flight back. Okay? Amazing. We can't do it. So he's going to continue to get business. But these patients are getting harmed. Okay? We need to engage the insurance providers better. Another discussion that we've all talked about for years as bariatric surgeons in the UK, because UK insurance companies do not cover obesity-related comorbidities, and that is their choice because they are the players and we just do as they're told. This is another opportunity for reframing that conversation. If I don't put my data into the NBSR, then everyone knows that I don't put my data into the NBSR. If you keep having problems and ignoring them, everyone should know that you have problems and keep ignoring them. So just like the college will name and shame us if we don't submit our data every year, because we should be getting out there as a group and saying, we want to look after our patients, and if you don't want to look after our patients, these are the places not to go to. We've got an NBSR, but we don't have a data set for this. So the reason Sanjay rang me up about this is because we were collecting some data. One of his trainees came to speak to us, and they were collecting some data, and it's kind of started like that. Chetan's spoken to me about it today. I'm sure that lots of people have experience like this across the country, and I think we need to pool this information to be able to have a sensible conversation. So I said I would try and leave it on a lighter note. So my message is, let's use these complications to try and do something positive. But if you want a real example of bariatric tourism, I came across this on the internet when I was looking up gastric band. And because I'm a bariatric surgeon, I thought this said gastric mid-band. And I thought there was a company out there that was solely promoting the old mid-band that we used to put in, and everyone loved when it came out, you don't have to suture it in, and it just holds it perfectly, exactly what you need and all those things. And then I read it again, and it's a gastric mind band, not a mid-band. So I went on to look a little bit more about it, and I found that the gastric mind band is also actually not that cheap. I then went on to look a little bit more about it, and I found that actually people are really happy with the gastric mind band, much more happy than the other bariatric tourism that we've talked about. So there's Phil and Holly on the sofa talking to this chap with his missus, because they felt this was real bariatric tourism. Because look, she fitted her husband with an imaginary gastric band, and do you know what happened? He took her on holiday. And that's real bariatric tourism. Thank you very much. I just want to say a big thank you to Sammy, who's sitting there, Simon and Vino and the business office who helped with all the numbers. So thank you very much.
Thank you, Sanjay, for a very good presentation. Do we actually know the size of the problem? How many patients are going from UK abroad every year?
I think we will only know if we actually all share our data. All of us look after these patients.
And
we have to pull our data.
again, about some ethical issues. Some of the cost. Why is the cost so low in some of these countries? Are they using the reuse, like single instruments again and again, or
Again, I don't know. I can tell you a few anecdotes from some of, one of my colleagues who works at Imperial tells me some of the worst or poorer practices back in Egypt. So yes, these are all gossip and rumors that we hear about using disposable equipment more than once and all the other things. I think ultimately it is the cost of labor is less. Okay, higher volume reduces the cost, and they are not seeing people as people; they're seeing people as a commodity. So if you are able to do that and do high volume, it's probably cheaper. They must have some amazing deal with
the follow-up cost and complications gets.
They're just doing. They're being a bit orthopedic about it. They're just doing the procedure and leaving it.
Now, I can allow one question before lunch. Any questions? Just one question before lunch. Sorry?
We've got a medical leave.
One more session. Okay, I'll conclude the session. Thank you.